Good afternoon, everyone. Welcome to Clinical Pathologic Conference. My name's Carl Wallenkamp. I'm one of the chief residents who many of you have rarely seen because I'm over at the VA. But came over here today to to support Dr. Blender in this case, which I think is very interesting. A lot of learning here always brings us back to the history and physical exam. So this is a case of a 22-year-old woman with no past medical history who presents to the emergency department with a painful and erythematous right arm. She describes nausea and vomiting, along with other symptoms you'll soon hear about, and is found to have anemia. And Dr. Morey Blender is here to assist us. I'll show you briefly our disclosures, of which I just want to point out the instructions were very unclear. And so I listed individual stocks that I own. So don't do what I did is really all I can say about that. IBM really fell after I bought it. So anyways, no one uses IBM. So CPC, I already mentioned the case, so we'll meet our expert. So I just want to speak briefly on the academic history that Dr. Blender has. And as you can see, he's a professor of medicine here in hematology, an associate professor of pathology and immunology. He did his undergraduate in Notre Dame, came here for medical school, left us for residency, University of Illinois in Chicago, did a fellowship in hematology in Seattle at the University of Washington, and then returned here for another additional fellowship training and postdoctoral research. And at this time, I'd love to hand it over to Dr. Blender.
Great. Thank you. If I knew you were going to show your stocks, I would have mentioned another book to read, and it's called 100 Bagger. So it's about stocks that have gone up 10,000%. So, and how you characterize them and how to find them. So that might be something to think about.
I'll put that on my reading list, yeah.
So this is probably, there's not anybody probably older than me here, so I don't know if anybody would remember this, but I would say Ed Reinhardt was the grandfather or the father of the CPC. He was really a lifelong St. Louis, and I want to give a shout out to him. He went to Soldan High School, which is in St. Louis, went to WashU for college, med school, interned in New York, but then returned here for the rest of his training, worked with Carl Moore, who was a hematologist by training, but an absolutely wonderful person, and was the chief of medicine, really led the university and the medicine department through some very expansive and wonderful years. And Ed Reinhardt really was a clinician's clinician. He also did some scholarship, but I think he's known as being a clinician and an educator. And he was the master of the CPC. So what that means is that he did all the CPCs. Every week he would get not just a one-liner, but a detailed history and physical and whatever laboratories were available in the 50s and 60s and talk about it for an hour and then say, well, this is what the patient's got. And more times than not, he'd be right. And that wasn't just hematology, that was everything. So I don't know that there's anybody that could still do something like that. And then I pulled a couple of quotes of his or about him from some of the obituaries that were written about him after he had passed away, that he was a humane and caring physician. He had the ability to empathize with patients who were suffering from their illness. He was kind to house staff. It's probably underappreciated. And he was very meticulous in his medical records, and it's something I ascribe to. If you ever notice my notes, if you know they're done because I changed the font to Georgia, which is the same font as the New York Times. So I think of my notes as all the news that's fit to print. And so, but let's change the topic now. Another thing is, how do I prepare for things like this? Well, this is from a fairly famous TED Talk a number of years ago, a guy named Tim Urban, and he was talking about how procrastinators work and how they can get by, and this sort of fit me. And so he talked about how to put a presentation together, how to put a seminar together, and this is what he recommended. You find out you're going to do a presentation, you spend a little bit of time thinking about it, you work on it a while, you put it away, you come back and do it, and by the end, you're ready for it. So that's not what he does, and that's not really what I do either. We're more like this. So we kind of think about it maybe, and then, got to do this pretty soon, and here we are. These are some of the things I think about now. First of all, it's a challenge and it's fun and it's great to work with really great people here. One of the things I find by saying myself saying now that I didn't used to say was, that's amazing. I'm never too early or too old to learn new things. So I think that's really important that we're always learning and getting better at the things we do. Another thing I say sometimes when people are having a bad day, and I said this after Notre Dame lost to Northern Illinois in a really terrible upset game, was it's okay. The sun is going to come up tomorrow. And then the last thing that I've said on times, now this doesn't apply to every case, but it does apply to a few. And I think it's really important that if we do the right thing here, we're going to save somebody's life. Could be TTP or acute chest syndrome and sickle cell. There are times when we make a big difference. Not always, but it's enough that it makes the job really a fun and important job to do. And so just to recapitulate the CPC, this has really a hard start for me because there's no past medical history. A young woman with a painful erythematous arm. I don't know if that means there's a rash or some other thrombotic disease or something. She has nausea and vomiting. Doesn't help me very much from a heme point of view, but she does have anemia, so we'll go with that. And somewhere along the line, probably the workup, the anemia will be important in her diagnosis. And thinking about this as a kind of a triangle, there's two important clinical findings: the arm and then the GI symptoms, and then the anemia, the laboratory findings. So I just want to make a couple comments about the anemia. First thing I tend to think about is how urgent is this? Is this person bleeding? Are they hemolyzing? Is this severe anemia? How fast did it come? So I think you want to get some idea of the urgency first, especially in the hospital or in the emergency department. And second, think about the clinical features. What are the personal family history? There may be some nugget in there that we'll get, even though the intro said there's no significant past medical history. The physical exam will be important. And then basic laboratory testing. So you'll find these algorithms with triangles and squares and arrows and yes and no. I try not to pigeonhole myself into that too much. So I kind of group things. I think about the laboratory testing. What can we do quickly? So CBC, including a peripheral smear, is often key. Things like markers of hemolysis, hematinics, which are the things you need to build red cells like iron, and then maybe a bone marrow exam. Especially in the hospital, less likely in the clinic, but in the hospital, I always wonder if anemia is from some other organ failure system. The one we think of most commonly is renal disease, but a lot of just sick people have anemia, and it's really just a window to the medical problems in the patient. And then lastly, we get into more specialized testing. I'm not sure how much we're going to need here. And I put a bone marrow exam may come up here, or maybe some other tissue biopsy to make a diagnosis. So on that note, I went a little bit long, but hopefully that'll give us a good start.
Yeah, thank you. That starts really well. I'll trade you here actually,
Okay.
because the top button on this one is a laser if you want to point things out.
Okay.
So just as another reminder, we have this 22-year-old woman. She's in the emergency department. Her arm is erythematous and painful. She has nausea and vomiting and has anemia. And to give you a little bit more history, she noticed a small bump and swelling in her right antecubital region 5 days prior that caused her to seek medical attention. She presents again now with new nausea, vomiting, fever, and fatigue. She is found to be anemic when she initially presented, which was a new anemia, and then has had increasing fatigue since that time, 5 days after 5 days. She is having difficulty keeping food down. She doesn't recall bug bites specifically. She didn't see anything, but she was in her basement prior to the bump and swelling the week prior, sorting around and moving things. Her arm has swelled. She has new darkened skin distally to the right antecubital fossa. There will be a picture. It's ecchymotic, and there is some pallor and surrounding erythema. And she has burning pain in this region without numbness or tingling. Happy to go into more history, but any thoughts that come to mind right now or questions that arise for you, Dr.
Well, I think somebody's raised the issue of a bug bite, maybe from the looks of the rash, without feeling a bug bite. And that is very typical, for example, for a brown recluse spider bite. You often don't feel the bite. And a couple hours later, you may get some like tingling or burning, and then it can really scar over and cause a major soft tissue necrotic region. So I would think about that. The fact that maybe you gave me too much information. The fact that she was was it her basement? Where did she go?
In her basement,
In her
yeah.
basement. So brown recluse spiders are reclusive, so they tend to live in dark, damp areas. These are not they're not very big. They're little spiders, so they're not something you would necessarily notice. They're not tarantulas. They're tiny little spiders. Um, and so a basement is a common place, or a garage. And the other thing about them is they're not out in the farms necessarily. They're very urban. And so the highest concentration of brown recluse spiders in this area is University City, actually. And so older housing and a lot of dark and damp places. So if we've maybe I'm focused too much on that, but you're sort of putting me down that possible pathway. The nausea and vomiting, I'm not sure. I would always be concerned about pregnancy, perhaps. The fever would be of concern. And then I think we'll need some more information, excuse me, on her anemia.
Yeah,
Let me
absolutely.
grab my water.
So a little more detail about the patient. She doesn't have medical history, as mentioned. She doesn't have significant surgical history. She doesn't have family history at this point. She does not answer to having any allergies. She doesn't take any medications, nor any over-the-counter medications, and she did not fill the medications that were prescribed to her when she left the hospital. And then her social history, she lives at home with her mother and boyfriend. She's employed as a housekeeper. She's never used tobacco. She has rare use of alcohol, but she does use marijuana every other day.
There's not a lot of information here that would point me in one direction or another. Nothing, for example, medications or anything that might explain the nausea and vomiting. Doesn't sound like there's any other GI related issues. So I just don't think we're going to get much more out of this.
Yeah. So on the review of systems, things that they elicited, she is also newly short of breath. She does have some abdominal pain alongside her nausea and vomiting. She mentions this small bump in her the crook of her right arm, and then she has been getting more lightheaded recently, and she has an on and off headache.
Yeah, it doesn't help too much to help narrow it down. I'm still kind of in the back of my mind floating this bug bite idea in my head and think about the anacubital fossa. So this might be hard history to get, but if you found that somebody was like lifting boxes or moving things and carrying them, and there could have been a spider there, and you carry it, and that might be how you get an anacubital fossa bite. So there might be something else to tease out of that. That would be difficult. Might be easier in retrospect than prospectively.
Yeah, absolutely. So on physical exam, when she arrives to the emergency department, her blood pressure 97 over 57. She's tachycardic to 135. I guess I didn't put these numbers in red because I see them so often. I apologize. She's satting 100% on room air. Maybe that's my fault. And her temperature initially was 37.3 Celsius, and then later was febrile in the emergency department. She's ill appearing. She has some scleral icterus. And then she has this area on her arm that I can show a picture of very soon with some surrounding swelling and warmth. Anything that, for example, the scleral icterus brings to your mind?
I was going to comment on that. I think we're in the differential of hemolytic disease, which I would put first since I'm a hematologist, but then obviously some acute liver disease, a viral hepatitis, or something like that would also be possible, might explain a lot of this. Thinking about her tachycardia, that's pretty stressed. And she's febrile, so it seems like she is pretty acutely ill. The first thing I would say is she needs to be in the hospital.
Yeah, that makes sense. Looking at that heart rate for a 22-year-old, she's barely into zone 2 training. So, maybe this is healthy for a moment. I kid. And this is a picture of her right arm.
Yeah, it's trying to think if it looks like a state or a country or something. It's hard to say, not exactly. So I think there is an area of necrosis here, perhaps, or maybe even some urticaria. and then it's pretty sharply demarcated. So sometimes you see that with microthrombi, like a hit, for example, would show something like that. A bite would do that too. Those are what catches my eye. I'm not the best at describing these rashes, but I think some of this is necrotic, and then maybe with some, maybe even microthrombi, something that's leaving this sharply demarcated area, a little bit irregular.
Makes sense. So you've already mentioned a couple of the diagnostics you might want first. So, for example, CBC. And so we'll come to this slide. I will show you these basics. Anything that comes out in the
Well,
chemistry and the CBC
we're
will be
supposed to
next.
start with the CBC, right? Isn't that the hematology way?
Well, here it
All
is.
right. Oh, well, there you go. So yeah, so it all sort of, if I was Scooby-Doo, I'd say ruh-roh. Um, there's a lot going on here, and I think her bilirubin is dramatically high. It's mostly indirect, but there's a fair amount of direct, so you just can't tell. And there are some liver enzyme abnormalities. I think it'd be hard to pigeonhole if this is purely hemolysis or liver disease, or maybe both. Um, Her white count is up, and most of that is neutrophil. So this could be some sort of bacterial infection or some severe inflammatory response. And then what's really notable is that she's really anemic. So anybody whose hemoglobin dropped from 11 to 4.6 deserves some tachycardia within a short period of time. And I'm going to say that's probably more of the bilirubin than anything. So I don't think you told us about her urine, if her urine was dark too.
Ooh, yeah. So she didn't describe her urine being dark, but when she was in the ED, there was some dark urine.
Okay.
So it sounds like, oh, I pressed the wrong button, of course. So,
Uh, so fair enough. So I would look at the CBC obviously first, because I think that's where I would start. And so the fact that her red count is down, her white count is up, and her platelets are normal, just that sort of pattern where it's different makes me think it's not a bone marrow problem, that it's not a bone marrow failure of some sort, like a pancytopenia, not likely to be a leukemia, even though the white count is high. So I think there are probably two explanations, maybe related, but I think there's a cause of the anemia and a cause of the high white count. And obviously a smear is important, but this is showing mostly neutrophils. So be mostly concerned about infection, maybe an inflammatory response. As far as the chemistries go, I don't have a lot to say about sort of the electrolytes. Um, she's been vomiting, and so that might account for some of this. It's the bilirubin and the LFTs that are most dramatic, and it looks like, just based on her history, combined with these labs, like there's some sort of acute viral injury, and that's where I would start.
one question I have
Or
is
acute liver injury.
it sounds like the way that the indirect and direct bilirubin are accumulating towards the total isn't immediately obvious. What levels would you say where you'd start to move one way or another? Would you have like a little
So,
heuristic, for
so the old
example?
saw in hematology is if you just had a purely hemolytic event, you would not get the bilirubin quite this high. It might be get to 5 or something like that. So when you see a total bilirubin this high, you do tend to think about some evidence of some part of it is liver disease. So that's from a hematologic perspective, that's the way we look at it. And I think the direct bilirubin, which will reflect more liver function, I think is up. Obviously, the indirect bilirubin is the rest of it, and that's very high as well. So pretty dramatic. And if all of the decrease in hemoglobin is from an acute hemolytic event, that's a lot of bilirubin being dumped into the serum or plasma.
Hmm.
You know, I don't think there's a good correlation, because I think the other piece of it is how fast it happens. And so it is hard to judge. Like if you lyse 1 gram of hemoglobin, how much bilirubin does that generate into the blood? I don't think there's a number like that.
That makes sense. And one thing I'll point out is that the first total,
Vicky?
yes. Mm-hmm. Mm.
So we always sort of know, and rapid is get rid of nausea, now that everyone seems to use marijuana. The other thing is that for dropping-included spider bites, which this looks a lot like that, it can also look like community-acquired MRSA. So whenever you're thinking about dropping-included, you can think about community-acquired MRSA infection. So usually are more pustular and have exudative sort of lumping up around the lesion. But oxalic which are the systemic complications of bronchitis, spinal flight, cause nausea, vomiting, cause elevated LP, fever, and then can cause this profound hemolytic anemia.
Yeah, so I don't know how much we should talk about that now, or if you want to wait a minute, but there is an enzyme from the bite that dissolves the membrane of the red cell, and that's thought to be the cause of this acute hemolytic anemia in the brown recluse spider bites. So I think a lot of this does fit with that diagnosis. I think also there are other things that would give a rash like that. I was thinking about other vasculitides, maybe even phospholipid antibody hit, or other microthrombotic disease can look like this, like DIC, but it's pretty localized. So that's why we're kind of gearing in on something local that triggered it, presumably. Okay.
Great, thank
Thanks,
you.
Vicky.
And just a point, as you mentioned, Dr. Fraser, about the marijuana use and that contribution to the nausea and vomiting. I think one of the things in CPC is we're always looking for that Occam's razor approach of one unifying diagnosis, but a lot of people talk about Hickham's dictum that the patient can have as many diseases as he or she damn well pleases. So that can also be an element.
I'm an Occam's guy myself. I try to put things together, especially in a younger person. I think in an older person, you do tend to find multiple morbidities at the same time. A little harder to explain, but in this case, I would vote for Occam.
Yeah. I'll show you the urine for a moment because you had mentioned that. And I was wondering if any of this would be illuminating to you, or how you might read through a urine study if you're expecting hemolysis.
So one of the key things I think that's not here, but that's important, is that there is 3+ blood. So one of the things you want to know about that is that hemoglobin or myoglobin from, say, hemolysis or rhabdo, or is it red cells? Oh, you do have it. We have red cells. So it's a little bit out of proportion. There's 3+ red blood on the dipstick or on the chemistry test, but by microscopy, there's a very modest or scant number of red cells. So that implies this is either hemoglobin or myoglobin that's in her urine. The urobilinogen is a little bit elevated, but I don't put much stock in that. There is bilirubin, which you'd expect because of the direct bilirubinemia. And the white count, I suppose it would be worth doing a urine culture, but I'm not sure that's going to get us the answer.
All right. Is there a study you would like next, or something you'd like to look into?
Well, I mean, if it was just me, I would do the anemia evaluation for next, but why don't we, let's do just initial imaging. We'll start with that since it's initial.
Okay.
So she had a liver Doppler, presumably for evaluation of the LFTs and
Precisely.
the bilirubin. Look for obstruction.
Right, and they didn't see any thrombosis. They had appropriate flow. The impression was that it was essentially a normal study.
Okay. One other drug that we didn't mention, and maybe it was in there and I missed it, but whether or not she might have been on an estrogen-containing oral contraceptive. So that is certainly a prothrombotic, and so maybe think about portal vein thrombosis or other thrombotic disease that might come into play, but presumably not.
She was not, per the
Okay.
review that they did. No.
Did you say that? Did I miss it, or did you not say it?
I did not specifically say that, but she is
Okay.
not.
All right,
She is
good.
not on it. What else would you
Oh,
like for this
that's
patient?
all we're gonna get.
You can have whatever you
Did
like.
we already do the urine?
We
Was-
did just we looked at the urine, disproportionate blood compared to the RBCs.
Okay, why don't we do a cardiac evaluation? I don't think that's going to be critical. This is probably a sinus tachycardia, but why don't we just go through that?
I didn't put the EKG in here because it's sinus tachycardia.
Okay, all right, take that one off. But it's important to do. You just never know. So I think we're down to kind of, this is a very common sort of triangle that we get into. And so there's often these very complex cases, even more complex than this one perhaps, but you end up with a triangle between rheumatology and immune diseases, ID and infectious diseases, and hematology, often with occult malignancies, low-grade lymphomas and things like that. And sometimes it's hard to get out of that triangle. Those can be very, very difficult cases. And I was afraid of that when you gave me this case. So I'm going to like miss some crazy lymphoma, but it's not looking like that now. So why don't we do the infectious? We'll do infectious rheum, and then we'll do the red cells or the anemia.
So here's the total. So the first blood culture set group gram-positive cocci clusters after 15 hours. She was still in the emergency department at that point. The second set was no growth. Her white count did continue to increase. And so I have kind of a question. If you see this patient coming into the emergency department and you are the only one in charge of the orders, would you start them on antibiotics?
Probably if they were febrile.
Okay.
I don't know what the right answer is, if there is a right answer, but I'd still be a little bit nervous about the pyuria, or the white cells in her urine, the fever, the tachycardia, just the overall sickness. I might.
Yeah, that makes sense.
Was there a right answer to that, Vicky, or what would you? Antibiotic?
Yeah, that makes sense.
And probably cover some staph coverage too with that lesion on the skin. So good. Vicky, Carl said I could ask people questions, so. That's right. Okay. So let's do
I think you
immunology and rheum are kind of almost the same. Why don't we do those two?
Okay. Well, I'll let you know there were no room serology sent, so I'll give you the immunology.
So a pretty high CRP. Sed rate is going to be totally unreliable because to sed rate, you're measuring the sedimentation of red cells, and there's her red cells are a third of normal. So that I would discount that as being worthwhile at all. But the CRP is fairly high. So some inflammatory infectious reaction here. Again, we're not in the rheum world right now. We're more in the ID heme world for the cause. And then my mitochondrial antibody screen, I don't have any real comments for it. I mean, it's negative. I'm not sure what I would say if it was positive. Because
We'd use the word that it was positive, yeah, but
Yeah.
I'd probably phone someone. All right.
So, we're left with anemia and pathology.
Yes. So I think you might want the anemia
I was going to
eval.
do that because the pathology is going to take a little bit of time anyway.
It would.
So if we try to do this in sort of real time,
we'll pull it up next week.
Yeah,
we'll pull it up next week. And we'll do the anemia right now. So there are a lot of numbers. There's a lot of red, partially because that's our theme color. But how would you work through these studies?
Whew. So, okay, so let's take them in the little clumps that they are. So if we start with the iron studies here, we see a lot of really funky looking iron data like this. So the ferritin is high, and first things people think of is, could it be a HLH? And that's usually not the first thing. This person has some liver disease, has incredible inflammatory response. The chance of this being HLH, I think, is remote. But the way I describe this to our fellows is this is an iron trafficking problem. There's plenty of ferritin, so presumably her total body iron is adequate at least, but you can't move it around. So there's very little in the bloodstream. The saturation is only 6%. So this would go with an acute inflammatory response. the increase in hepcidin blocks your ability to move iron around. So I think this just tells us this person is acutely ill with an inflammatory response. The B12, the folate is low, and I think that should be corrected. I don't know if there would be a reason for that to falsely be low. I don't think so. So I think that would be worth correcting. Could it account for the anemia? Probably not in total, but what could happen is if you can use up folate pretty quickly. We don't save very much folate or store very much folate. And so all of a sudden, if this person needs to make a lot of red cells, all that folate is going to be gone. This is a serum folate level, so it's going to measure an acute depletion of folate. So that would be my explanation for that. All the hemolysis labs are abnormal. Haptoglobin is almost too sensitive. It doesn't take very much hemolysis for the haptoglobin to be depleted. It's a scavenger in the bloodstream for normal low-grade breakdown of red cells, really to recycle the iron. That's what haptoglobin is there for. And there's tissue injury and then also probably an acute hemolytic event here for the LDH. The coags depends when they were done with respect to her anemia. The instruments are calibrated for basically a normal hematocrit or close to it. There's a range where you can get a reliable coagulation studies. But what happens is if the hematocrit is very, very high or very, very low, in the blue top tube that does the coag, there is some citrate. And if you're off in the citrate to blood ratio, to plasma ratio, it's going to throw off your PT. So I think that is a falsely abnormal result. And then I think that's it. And then no smear results because what happened?
You know, there just was not one. So I don't have a great reason for why there was not one done.
All right. And then the retic count is actually very low for the degree of anemia, depending on when that was done. And it could be that the person is not able to mount a retic response, maybe because of the folate, or it's just very early. It takes at least 2 to 3 days to build up to get from the erythroblast to a retic, and you can't really speed that up much more than that. So that would be something I would follow daily if the diagnosis was still in question. Make sure that eventually comes around. That is a very low retic for the severity of her anemia. And obviously, we really haven't talked about this, but it's not like a cold agglutinin, for example, because the Coombs would be positive for complement. It's not a warm antibody. So it's a non-immune hemolytic anemia is what I would say so far.
Well, thank you. Well, I want to show you in the next 2 days, interestingly, she then developed this rash. So this was a desquamating pruritic rash that found in multiple areas throughout her body. So you can see flanks, abdomen, left arm, between her breasts, on her chin, and then on her leg. Does this change your thinking at all about the patient?
I'm not
Does
sure.
it fit with a single diagnosis?
I'm not sure how much this goes with spider bite. I would be concerned about what Vicky had mentioned, a staph infection, maybe some other like a toxic shock type syndrome, maybe some other desquamating rash, maybe DIC, but I don't think so. I would say to have dermatology take a look at it. I'm not sure exactly how it fits in, but I think we still have to have some differential diagnosis here.
Yeah, that makes sense. So the patient was started on IV antibiotics, and I can talk about that later. Several teams were consulted, including hematology, in the patient's care. Emollients improved this rash, but I'd like to leave you with a question: what you're going to hang your hat on for this patient?
I think the story is too good for it not to be a brown recluse spider bite. So I'm not sure about the rash. I would ask Derm what they thought this was most consistent with, but everything else, I would call this a non-immune acute hemolytic anemia. And with a rash, the initial rash that looked like a necrotizing lesion from brown recluse spider bite. By the way, another name for brown recluse spider is the Missouri fiddleback spider, which is because it was most common in Missouri. It's throughout sort of the Midwest, lower Midwest, but some years we see tons of these, some years not so many. So, but there's a lot of spider bites. Not everybody gets necrosis like this, but I think it's possible.
Wow. I don't know
That's
if
what I'm
any of
gonna say.
you, I don't know if any of you feel a little bit more itchy right now, but we are all in a basement, so in Missouri. So, but let's give a round of applause to Dr. Blender for systemic moxiclism bitter brown recluse spider bite. Well, wonderful. Well, thank you. She received antibiotics for treatment of cellulitis. She received 100 milligrams of methylprednisolone. Hematology and toxicology were consulted. Given that the direct antiglobulin was negative, favored no further steroids for her. Her anemia stabilized after a total of 6 units of packed red blood cells. She awaits follow-up. Just a few points on the diagnosis. It is clinical, which was established with history and physical exam. It was augmented by our lab values. And then would like to give you a moment just to mention that there are these different elements in the venom that can cause the changes in necrosis. I'll just finish on a couple things and then hand that over. With regard to antibiotics, in some review of patients like her, they're both gram-positive and gram-negative rods, including Pseudomonas, so we favor broad-spectrum antibiotics. This is easily confused with cellulitis, thus patients are often seen and then discharged early in the course and then have to represent. And then the hemolytic anemia, can hand it over to you to talk briefly about any of the toxins that play a specific role.
Yeah, I think it is that phospholipase that damages the red cell membrane. So if you had a good smear and you knew what to look for, sometimes you'll almost see on the smear sort of a halo effect of hemoglobin that's leached out of the cell into the periphery. I've seen that with this, and I've seen it with Clostridia. That directly injures the red cell in the circulation. That's a little bit esoteric. I think this was an acute hemolytic event. You have to be careful and make sure there's no antibody issues because sometimes those can be a problem. In this case, not, but that's the other thing, and it should get better.
Makes sense. I want to show you the last slide that I have here, just pointing out that she developed this acute generalized erythematous pustulosis, and this is seen in patients with brown recluse spider bites, but it can also be seen more commonly with drugs that many of us use, beta-lactam, cephalosporins, azithromycin, sulfonamides, even clopidogrel, ticagrelor, apixaban can all cause this. And just to note that there's variability in onset. So for example, daptomycin up to 24 days after exposure, whereas with apixaban, there's been reports within 10 hours. Usually remove the offending agent, which is just an important principle of all internal medicine. And then you can treat with topical and then systemic steroids. So again, thank you so much, Dr. Blender.
Thank you.